is Diagnosis Glaucoma with your hosts, Dr. Mona Colleen
and Dr. Harry Quigley.
Hi, thanks everyone for joining us today. We have a very special guest. We have Dr. Sandra Sieminski, who is the interim chair at the University of Buffalo at the Ross Eye Institute. Sandy, can you please tell us more about yourself?
Hi, and thanks, Dr. Kaleem. It's been so exciting to join your podcast, and I'm very excited to tell your listeners about cyclophotocoagulation today, a topic that's near and dear to my heart. So a little bit about myself. I've been at the University of Buffalo for 15 years. I'm a glaucoma specialist. I did my glaucoma training in New York City at the New York Eye and Ear Infirmary with Dr. Bob Rich, who is one of the living legends of glaucoma, very unique individual. And I've been in Buffalo ever since, so the past 15 years. And little interesting tidbit, I guess, about myself is that I was an art major, a visual art major. So I actually was an art teacher before I went to medical school.
That's actually very interesting. I didn't know that about you. Just curious to know, did that help you in your career?
Absolutely. I think there's a lot of art in the eye exam and looking for patterns and differences in color and things like that. But also as a surgeon, I want my closure of a wound to look pretty. I care about how things look, and, of course, the obvious explanation of I'm working with my hands, and as do, painters and people who draw and things like that. So yeah, absolutely. There's a connection, and it's amazing. I'm at the University of Buffalo, so we interview a lot of candidates in medical school, and there are a lot of candidates who have an art background. So there's definitely some connection there with art and ophthalmology.
And then the follow-up question to that is, what made you go into ophthalmology and specifically become a glaucoma specialist?
Well, I think I tell a lot of medical students this. When you enter your third year, which is the year that you're actually going to the hospital and doing some of the work in person with patients, you kind of know whether you want to be a surgeon or not. It's just very apparent, I think, to most people. And it was to me. I wanted to be a surgeon. I wanted to work with my hands. I wanted to have procedural experience. So I did rotate, as everybody does, with the multiple types of surgery like orthopedics and ENT and so forth. And I was really interested in how specific ophthalmology is. I really liked the surgery. I thought it was something that was very delicate, very elegant surgery, and that was very attractive to me. But also, I really liked that mixture of seeing patients in clinic and then also doing surgery, and kind of being able to mix those two into one career. In terms of glaucoma, I have to say it wasn't my very favorite thing first thing in residency, because glaucoma at that time was, the only things we had available were really a trabeculectomy or a tube shunt, and there wasn't a lot more to offer surgically. I will talk about cyclophotocoagulation too, which has been around for a very long time, but all of these kind of fancier, minimally invasive glaucoma surgeries were not there. And, so it didn't appeal to me right away, but I did really enjoy following patients long-term. So having a long-term relationship with a patient, following them over years and years over the course of the disease, and really getting to know them. I think I have a personality where I like to chit-chat. I like to talk to people, get to know them and how their kids are doing and grandkids. And so glaucoma really lends itself to following somebody long-term and working through the disease with them. And then, of course, through my residency, the glaucoma surgery options really opened up and changed quite a bit. And it seemed even more attractive, I think, of all the ophthalmology specialties. I really loved how there were so many different surgeries that were coming out and so much development in the surgical realm of glaucoma, and that was very appealing as well. And I can't imagine myself doing anything else at this point.
And I've actually had the opportunity to hear you speak a few times about one of the procedures, the one we're going to talk about today, cyclophotocoagulation. Is that a procedure that you do a lot of, and what kinds of surgeries do you do and do you enjoy?
So I do a lot of it here in Buffalo, which is a pretty large city in New York State. Surprisingly, I'm one of the only people who offers this technology, and I was one of the earliest adopters back in 2015 to do it. So I would say I do a high volume of this laser compared to my peers in the area and even in my department. However, I think volume-wise, I do more minimally invasive glaucoma surgery, the little stents and goniotomy procedures that are available. I've either tried or continue to do almost every MIGS procedure that's on the market. And on top of that, I do the traditional trabeculectomy and tube shunts. So my go-to right now is the Ahmed ClearPath. I love that. And I should not be ashamed to say this, but I love doing trabeculectomy. I think I'm pretty good at it, and I do 5-6 a month, and I think it's a good procedure. I know we try to always develop more surgeries that avoid the bleb and avoid doing a trabeculectomy because of the potential complications. But if you do a lot of them and you really master the technique, I think it can be a surgery that can be very successful and kind of quick and, lower complication rate, I think, the more that you do a trabeculectomy. So I really do like trabeculectomy as well. Yeah, one of my residents said, you should start an Instagram account and make your name the Trab Queen. I said, well, I don't know if I like Trabs that much, but I do. So a long answer to a short question, but I do a lot of different types of glaucoma surgery.
Well, as we always talk about at meetings, the trabeculectomy is considered the gold standard glaucoma operation. Well, with cyclophotocoagulation, that works in a different way. Can you tell us more about what cyclophotocoagulation is and how it works?
Sure. So, I think your listeners are probably pretty savvy, I would assume, learning about all glaucoma and glaucoma surgery. And as you probably have figured out, all of those surgeries that we do, whether it's a hydrus, an iStent, trabeculectomy, a tube shunt, goniotomy, they're all meant to increase the outflow of the eye in order to lower the pressure. So with cyclophotocoagulation, it's kind of unique because we're not increasing outflow primarily. Micropulse, when we talk about micropulse, there is kind of a theory that it does increase uveoscleral outflow, but the main point of cyclophotocoagulation is to decrease the production. So you may or may not have heard the analogy that glaucoma surgeons are plumbers, but it's essentially turning off the faucet rather than snaking out the drain. So with cyclophotocoagulation, cyclo is a prefix that really pertains to the ciliary body, and the ciliary body is a gland that makes the fluid. So we're lasering the ciliary body in order to lower the aqueous production. So the ciliary body makes aqueous, which is the fluid that bathes the anterior chamber and contributes to the eye pressure. So this is a unique procedure because instead of increasing outflow or snaking out the drain, we're turning off the faucet.
And for all the listeners, just wanted to mention that cyclophotocoagulation can also be abbreviated to CPC. And there are the two major types of cyclophotocoagulation we're going to talk about today are the transscleral cyclophotocoagulation and also the what I call the micropulse laser therapy. There's a couple of other acronyms for that and ways to describe that. But so Sandy, for both of these, maybe you can just tell us a little bit more about the difference between the TSCPC, the transscleral cyclophotocoagulation, and the micropulse.
Sure. So Both of them are actually transscleral, but the first one, we'll call it just regular CPC so that we don't get too confused with all these acronyms. But the regular CPC, the traditional CPC, is essentially a laser called a diode laser that's applied to the ciliary body to basically, heat it up, decrease its functioning, and instead of going into the eye and lasering it directly, there is something called endocyclophotocoagulation, which we'll just not talk about today. Transscleral CPC or regular CPC, you're applying a laser probe to the outside of the eye. So through the sclera, you're going to be lasering the ciliary body. So you're not directly lasering it, you're doing it transsclerally. So traditional CPC is used, it's a diode laser, and the diode laser essentially is applied in discrete spots. So several spots around the eye, because the ciliary body is like a band or a circle around the eye. And that laser, as it's applied for, let's say you hold the pen or I call it a pen sometimes, but the probe on the sclera for 2 seconds, and the entire 2 seconds, the laser is being applied to the ciliary body. So you can imagine the ciliary body can get sort of heated up, and sometimes it can even cause an audible pop. And that pop is essentially the water content in the ciliary body heats up and almost sort of bubbles. So that is a very sort of hot laser, and it causes a lot of destruction. It gets the job done for sure, but it can be a bit more inflammatory and cause some destruction to the ciliary body and even some of the adjacent tissues. When we look at micropulse CPC, so we'll call that MPCPC, you can also call it MPTLT or micropulse translaser therapy. I think we can talk about why the company made a new acronym, but MPCPC is essentially same concept, different probe, same wavelength of laser, 810 nanometers, but it is actually the entire time that the laser is applied, only 31.3% of the energy is transmitted to the ciliary body. And how does that happen? It's micropulse, so it's sort of applied in an on-off cycle. So the laser is applied and then it's turned off and cooled as you're holding the foot pedal and applying the laser. So that concept was really created because, in that way, the ciliary body is still getting the laser energy, but it's not heating up, it's not popping, there's less destruction, and it's potentially less complications. So it may not be as hot and as strong as the typical CPC, and it may work in different ways than just destroying the ciliary body, but some more subtle ways. But it's still meant to lower the eye pressure in the same way we talked about earlier.
And what kinds of patients can have this treatment, like angle closure, open angle, like pediatric, glaucoma? What sorts of patients can have the traditional cyclophotocoagulation or the micropulse?
So because the CPC is something that can cause a lot of sort of adjacent tissue damage and a lot of inflammation, it was actually developed back in the 70s and was in wide use by the 1990s. It was a way to really lower the eye pressure in a low vision or blind, painful eye. And it certainly lowers the pressure, but it was really kind of used on patients that didn't have a lot of visual potential. So when micropulse came about, and it was actually first described in 2010, approved for use in 2015, it was still being studied in refractory glaucoma. And, glaucoma where maybe patients have already had multiple surgeries and have, more severe disease. And we'll talk about sort of how it started to be studied a little bit more in, let's say, patients with good vision, patients with earlier stage disease, And so now that has been widely studied, the micropulse in multiple kinds of glaucoma. So you can use it in pediatrics, you can use it in open angle glaucoma, angle closure, neovascular glaucoma. The only thing I would say is an active uveitic, so somebody who has active inflammation in their eye, because the micropulse still can cause inflammation, and you don't want to exacerbate that in a patient who has active uveitis.
And when would you decide which of the two laser treatments to do?
Well, I would say simply put, the CPC I would use in somebody who has a blind, painful eye, a patient with low visual potential for sure. Also, I'd say neovascular glaucoma is a type of glaucoma that can present with a very, very high eye pressure, and I think I would need kind of a bigger gun than the micropulse to really get that eye pressure down. With micropulse, I think, we could use that almost on any patient that has uncontrolled eye pressure. And I say almost because I think I would like to just say that a caveat is this is still not a procedure without complication. So I wouldn't use it on, let's say, a newly diagnosed open angle glaucoma when that patient has not explored less invasive treatments like drops or even SLT, selective laser trabeculoplasty, which is done in the office. So super early where patients haven't really explored the typical minimally invasive ways to treat glaucoma or non-invasive ways to treat glaucoma, I wouldn't really consider micropulse, but certainly patients who are uncontrolled on a bunch of drops, uncontrolled, and maybe they've had a surgery and they need more control. So like they've had a trabeculectomy or a tube or a Zen or minimally invasive glaucoma surgery. Those patients, I think all of them are fair game to think of micropulse as a way to control IOP.
And if a patient's had a trabeculectomy or another glaucoma surgery, can they have the CPC laser also?
Absolutely. So, from a procedural standpoint, we're going to be applying this laser on the outside of the eye. And with a micropulse, we're applying it in a sweeping motion. So we wouldn't want to, apply the energy, the laser in the area of a tube or a trabeculectomy, like right directly over it, because we don't want to harm or injure that area. But we have 360 degrees of ciliary body to treat, so we can certainly treat and just avoid those areas.
And you had briefly mentioned just, complications and risks. What are some of the things that you tell patients as risks for the procedure and potential complications?
So risk, I can say there's not a lot of 100% in medicine, but I can say 100% you're not at risk of an infection because we are not going into the eye. So unless for some reason the conjunctiva gets cut or ripped during the procedure, which is very unlikely. It's really not something that I don't put people on antibiotic drops, for example, afterwards, because there's not really, infection's not there as a risk. But certainly having some inflammation in the eye is a risk, but that's really treated preemptively with steroid drops. I use prednisolone for a few weeks. And that's a risk that's common, but fixable in most cases. And vision loss is another one. This is not without risk. And vision loss, I would say, can specifically happen because of cataract formation. So if a patient already has a cataract or doesn't have much of a cataract, but it's forming, this can sort of cause cataract progression. And also with the inflammation that ensues, you can have some macular edema, which can decrease the vision temporarily as well. Those are the big risks of micropulse CPC. Now, with CPC, again, because it's a hotter laser and more inflammation and so forth, and you're really more definitively destroying ciliary epithelium, you can have risks of having the pressure be too low. So that's called ptysis. And so too low is hypotony, but ptysis is the eye shrinking as a result of low pressure. So ptysis, hypotony, and more serious complications that really in the literature, if you go through all the micropulse literature, you'd be hard-pressed to find much mentioned about ptysis and hypotony with the micropulse.
And actually, another really good question that I just thought of is how the anesthesia works for this. Is this something you do in the office, or is it done in the operating room? And what are the options for anesthesia?
So when I started doing this in 2015, I know that we had been doing CPC, and I, even as a resident, had done CPC in the office. And if you did it in the office, you would do retrobulbar anesthesia, which is placing lidocaine or some kind of anesthetic liquid behind the eye with the needle, and then just doing the laser in the office. I did do my first micropulses in the operating room, even with that same retrobulbar anesthesia, and then a little bit of sedation. And I was actually very surprised because intuitively I thought, oh, this is going to be even easier because it's not as hot of a laser. But it was very stimulating to patients. Patients were uncomfortable. And I also am not, just a personal note, I'm not a huge fan of doing retrobulbar anesthesia. That's putting the medicine with a fine needle, the lidocaine behind the eye. So I worked with my anesthesia team to sort of formulate a kind of cocktail of sorts, which is given by IV, basically very heavy sedation. And we do the procedure without the retrobulbar anesthesia. That way I don't have to patch the eye afterwards. And that's all I do for anesthesia. Also a little topical lidocaine gel. And so 100% of my procedures are done in the operating room at this point.
And right after the procedure, is there an improvement in the vision, or like what actually happens to the vision after the laser?
Well, it doesn't improve the vision, and it's a good question, especially for patients listening, that most of the things we do in glaucoma with surgery is not meant to improve the vision, but it's meant to lower the eye pressure in the pursuit of saving the vision and preventing glaucoma progression. So this is absolutely pertains to cyclophotocoagulation and micropulse, is that this will not improve vision, and in fact temporarily the vision may be blurred for a variety of reasons, whether that's the prednisolone drops, whether that's inflammation in the eye, macular edema, so forth. You can have a temporary blurring or decrease in the vision, but typically this doesn't, at least with micropulse, does not affect visual acuity permanently in a negative way, but it definitely does not improve the vision.
And how long does this treatment take? And can you just kind of go into some details about what recovery is like?
Sure. So, there's different settings for the micropulse that we don't need to get into, but I would say generally speaking, this takes about a minute and a half to 2 minutes to actually apply the laser. But just with that, if any of you listeners have had eye surgery, it's not as simple as that. You come into the surgery center, you meet the anesthesiologist, you get numbing drops, you get an IV and all of that. You get wheeled into the room, you have the procedure, which is a minute and a half, and then you go to recovery, and then you kind of recover from the anesthesia, which is, I would say, in what I do, it's a lot more IV anesthesia than administered with cataract surgery. So people need to hang around in the recovery room a little bit longer. But I would say, of course, there are outliers and there are patients that may not agree. But I'd say almost all my patients are really surprised and happy with the fact that they don't have postoperative pain, any significant postoperative pain. They can go back to all of their activities. So there's no activity restrictions, again, because we're not going into the eye with an incision, so they can even go swimming, the next day. So there is a lot of, I think, patient satisfaction when it comes to postoperative restrictions and care. The care is just the steroid that I mentioned before. You don't have to shield the eye at bedtime or cover it or any of that. So, but of course, some people can have some sensitivity. Some people can have some discomfort. None of that really needs more than like a Tylenol or ibuprofen in terms of pain control. Again, in my experience, I haven't really needed to prescribe anything stronger for pain.
Great. And what advice can you give to listeners, or do you have any other comments about the CPC treatment?
I would say, it's certainly something to talk to your doctor about. If you are having a surgical discussion about, your eye pressure is uncontrolled and you are being offered a surgery, just, have a conversation with your doctor about MicroPulse CPC, because it's something that maybe could be incorporated into your treatment plan. And again, not everybody does the CPC, but your doctor may, have some information about it or some opinion about it. I do want to also just mention that the CPC, which we've been sort of putting into the category of only for blind, painful eye, super destructive or whatever, I don't want to give it a complete negative rap here, because I have been actually sort of using the traditional CPC with kind of lower energy settings for certain patients who may have had MicroPulse a few times and their pressure's still elevated. I can use the CPC on kind of a lower, cooler setting and sort of still decrease the amount of complications that can happen with traditional CPC with these lower settings. So I'm just, exploring that too from a research perspective. It's not a new concept, but it's called low and slow CPC. So that's something that I just wanted to let the listeners know.
Well, thank you so much for being part of this podcast today. We're really honored to have you, and we all want to support your work. So can you please tell us how patients can make appointments with you, or how we can just support you?
Sure. So I first off want to say, again, thank you so much for this invitation. I'm really honored to speak about this. We've done several research projects on CPC and MicroPulse, and it certainly has been a big part of my research, and I really think it's a great tool in our toolbox to think about when we're treating glaucoma. I am in Buffalo, New York, University of Buffalo. So if any of your listeners are in the area, I do see patients actually in a pretty large catchment area, even Pennsylvania and Ohio, Canada as well. So we are at rosseye.com. You can find our ways to make an appointment and read about our doctors. And if any of your listeners want to read more about some of the work we've been doing in research in MicroPulse and CPC, we'll provide a link to some of the bibliography on the podcast website.
Great. Well, again, thank you so much for joining us. And we look forward to seeing you on the podium and hearing your excellent talks. But thanks again to Dr. Sieminski. Thank you to the audience, and have a great day.
Thank you for joining us. Until next time, your mom says take your drops.